everybody to our webinar. This is the third webinar of 10 that we have prepared in Dystonia Europe. And my name is Adam Kalinowski. I'm the Dystonia Europe president. Dystonia Europe is a pan-European umbrella organization for national dystonia associations. And part of our mission is sharing the latest news about treatment and research on dystonia. And that's why we are here today. Now I will pass the voice to Monica, who will introduce our lovely speakers. So enjoy today's webinar. Monica.
Thank you, Adam. Hello, everybody. My name is Monica Benson, and I'm the Executive Director of Dystonia Europe. And I'm very happy to be here with you today, and also very happy to have the two panelists here today. And the topic of today is neuromodulation treatments of dystonia. Where do we stand today? And that will be presented by dystonia expert, Dr. Francesca Morgante. Welcome. And she's a neurologist specialized in movement disorders at St. George's University Hospital in London. And then also welcome to Dr. Fiorella Contarino, our other panelist. And she is a neurologist specialized in movement disorders at the Department of Neurology at Leiden University Medical Center in Leiden, and at the Hague Teaching Hospital in Hague in the Netherlands. And she will keep track of all your questions, and you use the chat box here on Zoom to and you can submit questions during the presentation, and then at the end of the presentation Dr. Morgante and Dr. Contarino will answer them. And we will try and answer as many questions as possible. And okay, I wish you a very nice webinar, and I hope you find it interesting. And I give the word to Fiorella.
Thank you very much, Monica, for the nice introduction. Thank you, Adam. And thank you to Dystonia Europe, first of all, for all you do for patients and people with dystonia, but also for organizing the webinars series and for inviting me to participate today. It's a special day because this is the last day of the Dystonia Awareness Month. So it's particularly important to be here today and answering questions on this very important topic. So I hope we can reach as many people as possible, and also that we can manage to answer some of the many questions that people with dystonia may have concerning neuromodulation treatments and the perspectives that are waiting for us in the future. So it is my special pleasure now to introduce my friend and colleague, Dr. Francesca Morgante, who is a well-known dystonia expert, not only for her clinical work and her research work, but also for her effort in spreading dystonia awareness. And I'm looking forward to hear to her presentation. So Francesca, the floor is yours.
Thanks, Fiorella, and again, it's a pleasure also for me, and thanks Dystonia Europe for organizing this series of webinar, and it's very special for me to be with my friend Fiorella, who is also a very well-known movement disorder expert, in particular a very well-known deep brain stimulation expert. So today you had the possibility to ask a question to a neurologist that is very experienced in that, and so we can both try to answer to many of these questions. So don't be afraid, don't be shy, and please type your question during the webinar. And again, I'm going to start here. I'm going to give a small presentation on neuromodulation treatment for dystonias, and just to discuss where we are with this kind of treatment, what the research is doing, if this treatment is for all types of dystonia. And the first concept that is important to highlight is that it's very important to remember that dystonia has multiple clinical manifestations, and we shouldn't forget, in the month of dystonia awareness, of the different types of dystonia, especially those that are more neglected as far as a treatment is regarded, because maybe they are focal, they affect particular task, and people is felt not to be so disable, whereas those type of dystonia can be really disabling. So let's try to give a look. This picture is showing that. So we have cervical dystonia, that is a dystonia affecting the neck muscle, and this can be quite disabling. It can determine pain, it can determine abnormal head posture, and also it can determine tremor. So within the cervical dystonia spectrum, there are also different types of cervical dystonia. Then we have people that can develop involuntary closure of the eyes, that we call blepharospasm. And when the involuntary closure of the eyes is paired with dystonia in the lower face district, we call that Mage syndrome. And this can be particularly disabling because people with dystonia and blepharospasm have to wear sunglasses, because when they are exposed to the light, their eyes closed, and they have if they have the lower face affected, they have movement in their lips that can affect their speech. And then we have upper limb dystonia, and upper limb dystonia can be very variegate. It can be very severe, like in this patient that have a fixed dystonia over the course of a Parkinsonian syndrome, but can be also can occur just in particular task, like for example writing in the writer's cramp, or like playing musician dystonia. Musicians are prone to develop dystonia. Sometimes we have seen people playing the violin, the piano, or like playing even the flute, different type of instrument, the drums, also the bagpipe. And dystonia may affect the lips, may affect the fingers, but surely has a big impact on the musician's life, because often these are professional musicians that if dystonia is not recognized and properly treated, they have to stop their career. They often are misdiagnosed as well. And then we have dystonia that is affecting just the trunk district, like in this child that actually has generalized dystonia but is more prominent on his trunk. Dystonia may affect just the feet, the lower limbs, and is well known that in children, usually dystonia tend to spread, to start in the leg and then become generalized. And finally, a very important manifestation of dystonia is tremor, that we call dystonic tremor. And often this may cause a lot of disability and can be embarrassing, but also bothersome for the patient, especially when it's affecting the head or is affecting the hands, and it occurs upon doing a movement. So it's interfering, for example, with holding a cup or writing. Before I go talking about neuromodulation for dystonia, I want to remind you that we refer to dystonia according to the body distribution. This is a way of classifying dystonia, and the reason why I'm saying that, because this procedure, this neuromodulation procedure, has been mainly developed for people that have segmental and generalized dystonia, but not only. So we speak about focal dystonia if just one body district is affected. If two contiguous body districts are affected, we speak about segmental dystonia. Multifocal dystonia is dystonia that is localized to different non-continuous body district. Hemidystonia we can see in children with cerebral palsy when dystonia is mainly localized to one side of the body. And generalized dystonia, it affects many body parts and at least must affect one leg and the trunk to be called generalized dystonia. So all these type of dystonias defined by body distribution indeed have different causes, and also that is very important. And I want you to focus on this is just summarizing the causes of dystonia. So dystonia can be a genetic disease, especially in children, whereas it's more rare to find genetic cause of dystonia in adult people. In adult people, dystonia is often idiopathic. Idiopathic is a word that we use in medicine to define that we don't know the cause. So I would not be surprised that with our growing research, we will gonna know that some of the people that have been previously categorized as idiopathic, maybe they might have a cause for that dystonia. But so far, most of the people that we treat and are adult with dystonia, they fit into the category of idiopathic dystonia. And then there is a group of people that have secondary dystonia. So we can find a cause. Very important to recognize functional dystonia, because functional dystonia has a different treatment from the rest of dystonia, and it's very difficult to diagnose. And these patients see many doctors, are often not satisfied with their treatment, and they might arrive to be assessed for having a surgical intervention, and they're not really patients that suit that kind of treatment. But also a cause for acquired dystonia is cerebral palsy. So when a patient had some problem during their birth, and so they have reduced oxygen at birth. An infection is very rare, but can be produced. Medication used to treat mental health conditions, like antipsychotic medication, can produce dystonia, and even sometimes vascular diseases is more rare. But the main causes are that, and we want always to exclude functional dystonia. So now let's talk about neuromodulation and the neurostimulation for dystonia. How does it come from? Actually, it comes from a lot of research that has been done into the dystonia field that has shown an alteration in two main pathways, or in two main networks, I will say. The first network that I would like to talk about is a network that is involving the basal ganglia. Dr. Shannon Shai talked to you about the basal ganglia in the first webinar. The basal ganglia are these important structures of the brain that are involved in initiating and programming a movement and in storing all the motor programs that we acquire during our development, during our life, and so we can retrieve them automatically. So the basal ganglia are a lot involved in organizing our automatic behavior. And if you think about that, most of the things we do are automatic. These basal ganglia are connected to the motor cortex, so it's the surface of our brain. And in the motor cortex is where there are the cells, the neurons that execute the action. And also this circuit is linked to the sensory cortex. And you all know how much the sensory stimuli can be really crucial for dystonia modulation. And this basal ganglia sensory motor network is also somehow connected to the lower part of the brain and the spinal cord that we call brainstem and spinal cord. And overall, all the studies have shown that the brain of a person with dystonia is very highly excited. There is a loss of inhibition at different level, and then the neurons, the areas of the brain show an abnormal plasticity. But overall, there is an increase, a decrease in inhibition. Another structure that recently has been shown important, another network for dystonia generation, is a network that is involving the cerebellum. That is another very important structure of the brain that is involved in coordination. We don't know what the cerebellum is doing in dystonia, but maybe we have hypothesized that the cerebellum is determining maybe the tremor component of dystonia. Those concepts seems very complex, but indeed the reason why I'm talking about that is because each one of these structures, the basal ganglia, has been a target for neuromodulation intervention, in particular deep brain stimulation, in particular a structure that we call globus pallidus part interna, GPI, and another structure that has been targeted by the deep brain stimulation, especially for people that have a tremor, is a structure that is called thalamus. So all these knowing what the brain is doing in dystonia and how the research contributed to that has been crucial to develop these neuromodulation strategies. We wouldn't been develop those strategies without knowing what was going on in dystonia brain. So let's talk now about how we can do this neuromodulation. So far we can use invasive neuromodulation that we call deep brain stimulation, and deep brain stimulation involves that there is a neurosurgical intervention, and two very thin wires are positioned into the structure of the brain that is very much affected in dystonia, that is the globus pallidus pars interna, that we call GPI. And over the last 20 years, this procedure that is invasive in the way that involve a neurosurgical intervention that in dystonia is done mainly on general anesthesia, obviously is invasive because we have to go through the brain, through the skull, and obviously there are risks related to this procedure, but can be a really life-changing treatment if the patient is adequately selected. So selection is very important in general in deep brain stimulation. If the patient is not suitable for that intervention, that would be very detrimental. So a wrong diagnosis would not provide a good benefit. And then there are non-invasive neuromodulation strategies that currently we are using them just for research. There have been a lot of research using different techniques that I want to show. At least there are 3 types of techniques. As you can see here from this figure, we can stimulate the brain underneath the skull from the outside with some type of electrical stimulators. This is called transcranial direct current stimulation, TDCS, or we can use a magnetic stimulus in a paradigm that is called transcranial magnetic stimulation. Again, all these paradigm, all these tools are used just for research. But I would like to talk about that today at the end of my presentation shortly, because there is a big discussion about these techniques. Sometimes patients come to us asking to be treated with these techniques, whereas these are just research tools, very important, but are not validated for clinical practice. So let's start talking about deep brain stimulation, that I will refer to as DBS. And first of all, which type of dystonia can be treated with deep brain stimulation? For sure, the 2 approved indications are generalized dystonia. Usually these are people with dystonia that have onset in childhood, but also they may have an onset in young adulthood, and they had spread to dystonia to many body sites, like this patient here that is a child. Or we can treat with deep brain stimulation segmental dystonia that is refractory to conventional medical treatment. And for conventional medical treatment, I mean botulinum toxin. And in this case, one of the conditions that we treat more, especially in adults, is cervical dystonia that can be focal and very disabling, or usually cervical dystonia, when it's very disabling, it's segmental. There is always an involvement of the upper limb, at least a subtle involvement. But cervical dystonia, when it does not respond to botulinum toxin, for several reasons, can be considered for the brain stimulation. The main criteria, and this is very important when we should consider this treatment, is when the patient have poor quality of life. So poor quality of life must be always the goal of our therapeutic intervention, even when we use botulinum toxin. So if the patient has poor quality of life and severe disability despite botulinum toxin treatment, that is an indication to consider the brain stimulation in, for example, cervical dystonia. Here, the main issue is that when we speak about cervical dystonia, the factors impacting quality of life are many, and in general in dystonia, because the perception that a person might have of quality of life can be really different from the other one. And among these factors can be that one person has abnormal head posture that is not corrected by botulinum toxin. One factor of disability can be that they maybe have some correction of the head posture with the botulinum toxin, but it lasts for just a short time, 6 weeks, 8 weeks, and we have to repeat the botulinum toxin every 3 months, and sometimes every 4 months, because the clinic does not allow to repeat every 3 months, but still it's just short lasting. And then after the initial benefit, patient develops severe pain, and this severe pain is highly impacting daily activities or even sleep. Sleep is really, for patients that are referred for deep brain stimulation, is a constant symptom that is reported, sleep impairment, also because it's really underestimated how many patients, when laying down on the bed, have their dystonia triggered, but just laying down on the pillow, and that can be really very, very disabling. Obviously, another criteria for disability is the tremor. So when the tremor is really very, very disabling, and again, it's really a personal perception, because overall into the dystonia world, I saw patients that have very high frequency tremor, so really having this, that is very, very fast, is not really very visible, but is still very disabling, because living with this constant tremor, it's really bothersome. Or even worse, there are patients that have these burst of tremor, a very large amplitude tremor of the head in particular position. So for example, if they're staying like this, they don't have any tremor, but if they're looking to something, if they are putting their vision onto something, they have very severe large amplitude tremor. And we have seen also young women refer to DBS for this problem, and this is really can be a source of disability. One thing that I forgot to mention, that, and I always say that dystonia patients are neglected because they really need a dystonia clinic and not just a botulinum toxin clinic. And one of the major issues when you have an abnormal head posture in cervical dystonia is that we underestimate what does it mean to live with your head tilted or turned to one side. Dystonia patients put in place a lot of compensations. So if you ask them, maybe you can see that they can cope just in that 5 minutes of the visit. But if you ask them, they will tell you that they spend most of their life in try to control the dystonia, try to compensate their dystonic movement. For example, a very frequent thing that they report is that when they have to go to see a movie at the cinema, they have to sit in a particular position, otherwise they are uncomfortable, or classically they have to lay down like this on a chair, because usually a very frequent sensory trick for dystonia is that to putting the shoulder on something. So if they bend their shoulder on something, they feel relaxed. And consider that dystonia affects a young age, and you lose a lot of confidence in living with such condition if you have such symptoms. So in general, just to conclude about the criteria for DBS in an adult that have, for example, cervical dystonia, when there is a poor quality of life for different reasons, can be because of stigma due to dystonia, because of lack of confidence, because there is difficulty to work. So it's very important to discuss with the patient what do they expect from the procedure, because I always say this is not a cosmetic procedure. We might improve the movement disorder, but if you don't know what is wrong with the quality of life of the patient, we cannot direct the treatment to improve this different domain of quality of life, because ultimately we want that. We want to have an individual that go back into the society and is functioning. So now we talk about a very important topic. So how many dystonia patients are candidates for deep brain stimulation is unknown. For sure, there is a big difference between childhood dystonia, that is producing generalized dystonia, and adulthood dystonia. I would say that children with dystonia, deep brain stimulation has become one of the major major treatment, because generalized dystonia is for sure very disabling, and it occurs during the developmental age, and some of these children also have so-called dystonic storms that can be an indication to do the deep brain stimulation. So as a tool for child neurologists, deep brain stimulation for children, generalized dystonia is considered more frequently compared to an adult. But where we are with the adult, because that is the real issues. I show you that we have different types of dystonia. Do we consider deep brain stimulation for focal hand dystonia? Do we consider deep brain stimulation for blepharospasm? Do we consider for leg dystonia? As I told you, the main dystonia that we consider deep brain stimulation for is cervical dystonia. Sometimes we might consider in presence of a very prominent bilateral dystonic tremor of the upper limbs, deep brain stimulation for this patient as a part of treatment of people that have tremor. But in adult, it's really cervical dystonia and that we want to target, for which we have most of the evidence. But despite we have evidence that this procedure is effective for adulthood cervical dystonia, we don't know how many are the people that should receive or are suitable for this. What we know is that at least about 30% of the patients with cervical dystonia that are treated with botulinum toxin in an American study, in a very big American study, they stopped their botulinum toxin treatment. And we don't know why they stop. So in this study was not explored, but we suppose that 30% maybe they stop because of not enough effect of botulinum toxin, or because they are not happy with the treatment, or because the treatment was not performed in an adequate way. It didn't target the aims. For sure, there is a proportion of patients that do not benefit from botulinum toxin treatment and can be triaged to be considered for deep brain stimulation. The real issue for us is that this is a treatment that is managed by an expert team, and this is not the issue. This is actually a mandatory criteria, but it's very important that a very expert and multidisciplinary team evaluate the indication for deep brain stimulation for many reasons. First of all, because we need to be very sure about the diagnosis. Second of all, because we need a team that is expert in programming the DBS system in people with dystonia. And third, we need to take care of also the other aspect of dystonia, for example, the psychological aspect. And just, you know, to repeat one concept, sometimes I've been referred patient that they felt that they were not doing very well with botulinum toxin treatment, but their neurologists felt that when they were assessing them, actually the botulinum toxin treatment was improving their symptom. However, the time constraint of a botulinum toxin clinic, sometimes it doesn't give us really the possibility to appreciate the complexity and the disability of dystonia. So if you feel that your symptoms are not fully improved by the botulinum toxin treatment, discuss with your neurologist, not just about surgical procedure, because as I told you, surgical procedures are just for a few patients, but also about using other tools like, for example, a rehabilitation tool. And again, here is just to show you how is working the system. So this is a brain pacemaker that is positioned under the collarbone, and then the wires under the skin are connected to this electrode, and the electrode is inserted by the neurosurgeon during a general anesthesia intervention in this deep structure of the brain. And the target that has been used mostly for dystonia is the globus pallidum pars interna, so the GPI. Although, like in some country, for example in China, they might use also another target that is called subthalamic nucleus. Some groups have been used the thalamus to target dystonic head tremor, but there is really little evidence on that, but can be used on that. This is the DBS electrode that have, you see in yellow, these are the active contacts that are used for the stimulation, and there are really a lot of combination that we can use. This is simulating, you know, the current. This is activated by the electrode contact. We can change the amplitude of the current. We can change the pulse width, the frequency, which site stimulating, if one site or two site or even three sites, if steering the current in different parts of the system. Really, the combination are a lot, and really it's a very difficult job for the neurologist. And I always say it's a long pathway that then leads to the benefit. And the patient must be aware that the neurosurgical intervention is just the first step of this process, but then we need to program. We call programming session, this consultation in which we meet the patient and we try to find the best pattern of stimulation. We try to find if there are side effects of the stimulation, because also the stimulation can produce some side effect just for the stimulation itself. We are in a very small structure that is surrounded by other parts of the brain, and if the electrode is not very well positioned, or even if it's well positioned but we need an high current, we can determine side effect, like for example speech problems, also gait problem, the difficulty in walking. So, and now let's talk really about the side effect for DBS. Are there any adverse effect of DBS? Obviously, we cannot forget that this is a neurosurgical intervention, so this is very rare, but that might occur. We can have bleeding from the surgery, and again, it's very important to have the best candidates, because if you don't have concomitant diseases, if you are at your young age, if your brain looks fine in the brain scan, this risk is really minimized. Then there are borderline cases that we decide to operate, but again, this is in the hands of an expert team, and there are risks that must be discussed carefully with the patient. So you cannot go just, okay, I'm gonna have this intervention, like, you know, it's something easy to undergo too. There might be infection of the system, especially after surgery, because we position this pacemaker that can get infected, or in the trajectory of the system, in the wire trajectory, the skin can have some erosions and then can affect the system. And sometimes when the infection is severe, is not curable, we need to take off the system and wait for 6 months, 9 months, and then consider if putting it again. Then there are some complications related to the system itself, because this is an electrical system, so it might fail because of different reasons. Sometimes are easy problems to rule out. For example, I had one patient that recently had a problem with the battery, so we had to change the battery, and that actually improved the symptom of dystonia, because the previous battery did not work nicely, and the dystonia symptoms were not improved by DBS. So but just by changing the battery, there was a problem in the battery, we could treat dystonia symptoms. And then there are side effects due to the stimulation. As I told you, if we increase too much the stimulation, or if there is not perfect positioning, we might determine this side effect. Again, I don't want that people to be afraid, because we don't want that, you know, people are scared and they don't want to consider that. I think it's good to discuss. It's very important that as a part of the screening for this procedure, this side effect and the risk, the probability for this side effect is discussed by the deep brain stimulation team, because obviously this is all managed by the deep brain stimulation team. Which are the benefits? So what happened with deep brain stimulation? So when the brain stimulation is successful, dystonic postures improve, head posture improve, dystonic movements improve, tremor improve very much, also pain, and in general there is improvement of quality of life. We also have seen people with dystonia that were able to go back to their full-time job, or we could see people that were more confident even to start a relationship. That is a very important thing of life, because we are human beings and we need to interact with other human beings. Although in this period it's not so easy to have a face-to-face interaction. So in general, when the system is successful, there is an overall reduction of dystonia and a really very big impact on quality of life. If you want to know more, I suggest really to listen to people, you know, experience. This is one of my patients, Lucy, that has been part also of our dystonia talks with Dystonia Europe. And if you go on Dystonia Europe channel, you can listen to her journey with the brain stimulation. Lucy also have a blog in which she have told YouTuber about her journey with the brain stimulation, and she really explained how difficult it is and how long is the pathway, but ultimately is leading to an improvement of symptoms. But then to go back to the improvement, I always ask myself, is dystonia just a twist? You know, like dystonia is defined by determining this twisting movement. Actually, as Professor Janashai showed you in the previous webinar, dystonia has high frequency of anxiety and depression, and we cannot neglect these symptoms. I had to tell you that all my patients that arrived for the brain stimulation, they had depression and anxiety. Some of them also had suicidal thoughts for many reasons, because of the dystonia, because they could not continue to live their life. So as part of the team, it's very important to have a psychiatrist and a psychologist involved to determine if the patient is fit to undergo such a big change with the surgical intervention, because we don't want even people to have too many expectations on this surgery, and if the expectations are not met, they feel betrayed. On the other side, if there is a big change with the neurosurgical intervention, you might transition from being very disabled to be able to function, but you have to consider that you did not function very well for the rest of your life, for the past 5, 6, even 20 years. So this is called psychosocial adjustment. It's very important to guide the dystonia patient that is receiving DBS into this psychosocial adjustment, so they can, you know, they can start to live with more confidence. So that all of that need a lot of care and a lot of care for mental health symptoms of dystonia that we can see they really might improve after DBS, but they don't magically improve. They really need support. So sometimes the brain stimulation doesn't work. And why doesn't work? We need to deal with that. And sometimes it doesn't work because there is a wrong selection. And there is also research published on that. Actually, there is a big study from a group of experts in dystonia treatment with the brain stimulation. And among one of the causes for lack of success of DBS, there is a wrong selection, and in particular functional dystonia patient were triaged to the treatment. And as I told you, functional dystonia do not benefit from the brain stimulation, and this is an exclusion criteria for the brain stimulation. So it's very important because these patients are really very disabled. They really need a lot of help, and but the brain stimulation is not the treatment for them. We don't know if there are genetic factors. There was a time that we thought that some type of genetic dystonia might be more or less responsive to the brain stimulation. It seems that sometimes of genetic dystonia, like for example, one mutation that is called DYT1 determine more benefit, where other do not, or maybe because dystonia is progressing because it's just part of a more complex neurological condition, or in children because there is spasticity that is provoking the disability, or there are brain lesion. Sometimes because we don't have an optimal targeting of the brain stimulation electrode, because you know, the electrode is not being placed in the right side, or this is very important, there are unclear goals and the expectations are unmet, and this is really betrayal for the patient. And again, good selection is good outcome, so we should never forget that. Last slide are about non-invasive stimulation for dystonia, and I want to give you some insight from the research world, because you might feel that, you know, we are just talking about generalized dystonia, very severe cervical dystonia. So what we do for the rest of other dystonias? There was a lot of research about non-invasive neurostimulation, neuromodulation, and that's as I started with this technique that we call transcranial magnetic stimulation, TMS. So this is a magnetic stimulator. This is called coil. This is just a cartoon of the brain, and this is the motor area. And we deliver a magnetic stimuli with this coil, and then we register a motor response. So we can stimulate the brain with this magnetic stimulation, or we can stimulate the brain with this electrical direct current that is called TDCS, transcranial direct current stimulation. And this is quite intriguing because this is a portable system, whereas to do this technique you have to come to the research lab, and if you would have some really consistent data about this technique in the future, that is very much underdeveloped so far, but this would be really a portable system that the patient can do at home, because one of the main difficulty here is that if you have a system that is not invasive and you have to go to the hospital every day to have that system, it's not really very much easy to use in real life. There have been some studies on using non-invasive neuromodulation, mainly in upper limb dystonia. So people that have or focal dystonia of the hand, or just writer's cramp, so dystonia when writing. Overall, there have been actually 15 studies on this cohort of subjects. On people that have craniocervical dystonia, just 3 studies, and in people with blepharospasm, just 1 study. So it's just, it's a novel research, it's just starting, but there is a growing interest, even because the technologies are, improving, and there is more connection between bioengineers and researchers into the dystonia field to work on that. Where do we stimulate? There are many sites of stimulation, so this is one of the major gaps. We don't know which is the best area. It seems that the best area for focal and dystonia for Bratte's cramp is the premotor cortex, that is just beside the primary motor cortex, is the area that is involved in the programming of the movement. And if you remember my first slide on the mechanism of dystonia, the goal of these techniques is to reduce the excessive facilitation in the motor areas of dystonia. But which are the results? We have mixed results. Mainly are negative studies. A few studies, however, reported an improvement with TMS done over the premotor cortex in focal and dystonia. There is a very famous study done by our Japanese colleague, Dr. Murase, that actually used an electronic pen to have an objective measure of the writing that has help. But still, we don't know how many sessions are needed, how many days, 2 weeks are enough, how many times we have to repeat, so we need like a research to be funded to explore the usefulness of this technique. And nevertheless, these are research tools very important to understand the mechanism of dystonia, because they contributed to our understanding of dystonia in general, how it's produced. So conclusion, DBS is effective to treat childhood and adult dystonia with poor quality of life. I would say yes. So we can say that is effective in improving abnormal posture, tremor, and pain. However, this is a procedure reserved to a subgroup of people with dystonia, and careful selection is mandatory, and the selection must be managed by an expert team, that is a team expert in the brain stimulation, and this multidisciplinary team also must involve a psychologist to take care of the mental health problem of dystonia. And regarding non-invasive neuromodulation, just research application in dystonia, and is not an approved treatment, and more studies are needed. But I'm very confident that would tell us a lot in the future, and maybe we can even help people that have focal dystonias that do not have any improvement with other treatment, and they cannot be considered for the brain stimulation. And this was my last slide, and I would like to thank our team in St. George's, especially our neurosurgeon, Mr. Arlic Pereira, and Professor Mark Edwards, with whom we run the dystonia research team. Thank you.
Okay. So what I liked a lot of your presentation is that you gave not only an impression of what is possible today, but also maybe a hint of what will be possible in the future with these other neuromodulation techniques. So that's very interesting. Maybe one of the things that's very important, I'm reading now the question that's coming. You mentioned that DBS can help a lot of people with dystonia, can improve their symptoms and improve the quality of life. But lots of people are afraid to undergo this treatment. And I mean, it is correct to ask themselves the questions, because it's a surgical treatment and can have potentially serious complications. So you mentioned this, but can you quantify what is the risk of having a serious complication?
Obviously, it depends on the that center percentage of side effect. In our center, the risk of a serious side effect is less than 1% of patients, and so it's very, very low. And we had serious side effect when I talk about bleeding in people that had neurodegenerative diseases, but not in dystonia, for example, we never had so far. But again, what is very important is our numbers, because obviously in a big center there are big numbers. In a small center there are small numbers, so that percentage might change. Obviously in our big numbers, that percentage is still very low, but also this is affected by the way we do the selection, because we are very strict in the selection. Obviously, if you go just on the on the borders of selection, the risk of side effect might increase. Obviously, I don't know, Fiorella, but I'm seeking to hear your opinion, because it's not that it's not a procedure that you come to clinic, you have a usual consultation, and then you decide about that. I would like that people understand that it's a long process. Sometimes I educate them. I can see that from the type of dystonia, how is it? And so no, I just guide them to arrive to that. What do you do? What do you do in your practice?
No, I perfectly agree. This is not like just the next pill that you can try, and then if you don't like it, you just stop with it. It is a procedure that has consequences. I share also the same percentage from our center. We are quite a large center. We do 50 procedures per year. And until now, I think we have done some 450 procedures, and our percentage is also 1% of serious bleeding. 1% is very low, but it's not zero. So that's why we don't just do DBS to everybody. We select the patients very well, and the selection is aimed, first of all, at reducing the risk. So we exclude patients where we think there are more risks, and also including the patients where we think that they can have a significant improvement, because the procedure should be worth the even small risk that they are having. So it's never a one-step decision. We have a screening process where the patients, if they come from other centers, they see the neurologist at least twice before going into the screening procedure. Then they have a full screening procedure. After that, they have a chance again to talk to the whole team. So neurologists, neurosurgeon, the nurses. And then if they decide to go for surgery, there is another meeting with neurologists and neurosurgeon to talk about the details. So there is a stepwise procedure, and people have to realize that it's a very heavy surgery in general, but also not only the surgery itself, but the period after surgery, the stimulation needs to be adjusted. So it's also not so that you have the surgery and the day after all the symptoms are gone, unfortunately. It's a process that starts and sometimes may require months or even a year before you get the effect. And sometimes there can be side effects. Yeah. So it's a long process.
And in that regard, obviously, I use that tool for dystonia quite a lot. I mean, like at least I screen because I think that it's always worthy in my patient to screen, even because the screening gives us the possibility to spend a lot of time with the patient, and we understand better their needs because they do a careful, extensive evaluation of different systems, different symptoms, the motor symptom, the non-motor symptom, the psychological symptoms. So even if at the end they are not interested in the procedure or we feel is not appropriate, it's always good to do the screening in particular types of patient. And this is why it's a long process. For example, our team, after we do this big meeting that we all the team meet the patient, but after the patient is selected, we organize workshops with the psychologist to prepare them to the consequence of DBS, because as you pointed out, it's not just the surgery, then it starts just not a pathway, and patients need to be prepared on that, because if they expect to be healed after the surgery, this is not the case. This can be just a disappointment for them.
Yes, and even when you have the best results that you can expect, it is still a major life event, because maybe people have been living with dystonia for so many years, and then at one point the relationship changed, they are more independent, they can do things they couldn't do before. So this also, even if it is a positive change, it needs adjustment and psychological support, definitely. Okay, there was another question, and that's also interesting because you mentioned that DBS is usually indicated for people with generalized dystonia or cervical dystonia, but we didn't go too much into the cause of dystonia because there are different causes of dystonia. So is DBS good for all the causes of dystonia? For example, there was a question, does DBS do well for patients with dopa-responsive dystonia?
Interesting. So no, it's not good for all the causes of dystonia, because I said that, for example, it's not good at all for functional dystonia. So this is an exclusion criteria. If you have dystonia after stroke, a very disabling dystonia, for example, we had operated a few cases that had a cardiac arrest and they had post-anoxic dystonia. That is a very risky surgery, but these were adults that were very disabled, and we have done DBS, but it must be considered quite carefully. And again, predicting the improvement after that, it's really very difficult. For genetic conditions, it depends on the types of mutation. Few mutations seems to improve better than other. I think in that regard is not the mutation, but is the type of dystonia. Is really if there are more tonic posturing, is more affecting the speech, because for the speech usually the DBS doesn't improve so much. Although we have few cases that their speech has improved a little bit, but usually it does improve, but even might worsen the speech, because there are the structures that, you know, are determining that. For dopa responsive dystonia, I don't know. I mean, like, I'm not aware of studies that have explored DBS stimulation in dopa responsive dystonia, because the natural history of dopa responsive dystonia is that usually to be restricted to the lower limbs, although I have been following families that had also dystonic symptom in other body parts after many years, but usually it affects just the leg, and so is not considered for the kind of disability, even because it responds very well to levodopa. The problem with dopa responsive dystonia with aging, that the patient wears off, so they have wearing off. I have to deal with that, and then basically I treat them as I do with Parkinson patient. I try not to have the other medication to prolong the duration of levodopa, but they don't develop severe disability in order to get the treatment. You, Fiorella, are you aware about these studies? There's some studies about that?
No, I also follow some patients with dopa responsive dystonia, and in general, by definition, dopa responsive dystonia responds to levodopa. So most of the patients are satisfied or relatively well controlled with medical treatment. And in that case, it is not indicated to do a surgical procedure. If there are patients that are not responding to levodopa, or they cannot take levodopa for some or another reason, well, that might be discussed in the team, but then you have to consider that it is a sort of experimental indication, because the condition is very rare, and because it responds well to medication, there will probably be no patients or very few patients that have got the procedures.
Yeah.
I would not advise. Yes, there is another question that is about, well, concerning after surgery, people have this implant. Can they do everything, or are there things that they cannot do? For example, can you have a mammography with DBS?
Yes, you can have the mammography, and now with the new devices, you can also have an MRI scan. You need to configure the system in a particular way, but there is a lot of support. We have a patient that needed an MRI, and we have done the MRI. So, but the mammography for sure you can do. So yeah, this is not a contraindication. Obviously, with the MRI, the system must be switched off. And we organize the MRI here in our hospital, because then we are in control and we can, you know, manage the system. It's safer. I don't know if you do that as well, or, you know, like.
No, yes, I agree. The mammography is technically possible, only it very much depends on where the battery is placed, because if the battery is placed very deep, close to the breast, it can be technically difficult to perform the mammography. And especially you have to be careful that the people don't stretch the wires while trying to do that. So it can be a little bit tricky, but it is possible to do that. And the MRI, again, it depends on which system you get. Most of the systems nowadays can have some sort of MRI. You have to switch it off, and it all depends on the symptoms that people have. Sometimes it needs to be under sedation.
I think one question that I have for you is that we never discussed the case is that pregnancy, because in my experience, I had young women, but I never experienced having a dystonia patient with DBS having a pregnancy. I experienced pregnancy in a dystonia patient, but not with DBS. Have you ever had that to deal with a pregnancy in a DBS patient with dystonia?
No, not yet, but I know that there is a paper published from the group in Grenoble where they collected 4 or 5 patients with dystonia who got pregnant, or dystonia or other conditions who underwent DBS, and after that they got pregnant. So that's not a contraindication.
No, but that's why I think it's important, because like young women, I had this conversation with, because this, especially cervical dystonia, affect women. So young women, and they're willing to start a family, and they might be discouraged because they had the DBS system, but it's not a contraindication.
That's not a contraindication. And talking about things you can do or you cannot do, there is a question about sport. Can you do sport and after DBS, and can you swim?
Okay, so this swimming thing is becoming a hot topic now in general for people that have movement disorders. So you can swim. Obviously, you can do sport. We recommend, obviously, that you don't do risky sports, you know, that you can hit your head, or I don't know, if you're doing bungee jumping, for example, it's not a sport that I recommend. We have seen, especially our Parkinson patients with DBS are quite active. So going on a bike is possible, swimming is possible, Nordic walking is possible. Obviously, I don't recommend box unless it's a steady box. And but yeah, usually you can do. We had a question from our recent patient that is going to add the system if we could do scuba diving, because that is a big passion. And so we became expert also of scuba diving and DBS. And actually, yes, he can do it. Is recommended until a certain depth. So it shouldn't go too low. I don't remember. I think it's 50 meters.
I think it's 7 meters.
7 meters?
I think it's 7.
I remember more than that, but there are limits that obviously the company has also tested the system for that.
Yes.
So in that regard, there is knowledge on that. So
I think my advice will be to anybody who has DBS system and has doubts about what is possible or not, just contact your neurologist, and if they don't know, they will contact the company.
Yeah.
But it's better to ask one question more than to do something dangerous.
Always, yeah.
But we can also tell in the activity of daily life, there are almost no restrictions. It is metal object, so if you pass metal detector, it will alarm it, so you have to say it. And there is also a chance that the stimulation is switched off by a metal detector, so patients with the DBS will get a sort of passport, medical passport, and they are allowed to be just searched by hand. And the MRI we mentioned, the contact sports, box, or bungee jumping, parachute, these kind of things. We also don't recommend diving onto yourself head. And then there is one little information that if you need to get a surgery, there are some medical things that cannot be used during surgery. So you have always to inform all your doctors, physiotherapists, that you have a DBS system. Unfortunately, a lot of even health professionals don't know deep brain stimulation, but what you can always tell, it is more or less the same as a heart pacemaker concerning contraindications of medical devices. So that helps usually quite a lot.
Yeah, it's a brain pacemaker.
It's a brain pacemaker. Yeah. So if you say pacemaker, people know what you're talking about. And the last thing is when you have to get an ECG, the stimulation can give an artifact. So it is advised to switch it off. We also didn't mention most patients can get also patient controller. And with the patient controller, you can switch the stimulation on and off, and you can check it, and you can perform even some tasks. So these are, I think, the most important things to know.
Actually, now that you mentioned the remote control of the patient, I use it a lot, especially during this pandemic. It was really very helpful because people could not come to clinic, and so we had done this video consultation, and sometimes they were just afraid that something happened to the DBS system, so we could just check their parameter with the remote control, making a small adjustment, and so that obviously you cannot do big changes. But again, the technology is improving. There is, I didn't have the time to talk about all the technological developments in the DBS world, but we are more confident that maybe in the future we will be able even to make big changes remotely. No, we cannot do that now, but I'm sure that in the future we could do that.
Yeah. Okay, there's another question about indications. And it says, would you consider DBS for a person with spastic torticollis who can still function completely with only moderate head tremor and slight rotation?
Okay, so again, you said that. So I suppose that for spastic torticollis, you mean that is a fixed dystonia of your neck. So
or cervical dystonia, maybe.
Yes, cervical, yeah, yes, of the neck that is very, very tonic dystonia.
No, it says, sorry, it says specifically moderate head tremor and slight rotation. And then it says, I think some neurologists might consider this option too lightly. So the question is more about how severe must the symptom be to go for DBS?
Yeah, I think that she said, like in the text, because she said that who can still function completely. So if the patient can function completely, again, this is not a cosmetic intervention. This is an intervention that we consider to improve function. But if your function is complete, we don't consider. It's really inappropriate to consider. That is the first thing, discussion of goals. Then, if you cannot turn your head, if your tremor is severe, if you cannot live your life because you cannot drive, you cannot read, you cannot watch TV, you cannot interact with people. Before DBS, we do this scale of quality of life in dystonia. We rate the quality of life. So, and this score goes from 0, that is good quality of life, to 100. If your score is 10, if your score is 20, your quality of life is not impaired. But if your score is 80, because you answered to lots of questions that you are impaired, that means your function is impaired. So if you function completely, no, you're not a candidate for that.
Yeah, so it's very important to say the quality of life is very subjective. Every patient is different, so every time is a case-by-case evaluation. And I will never answer a question like this without seeing the patient, whether a patient is a candidate or not. You have to talk to the patient, it's exactly what you say, and see what impairments that you have in the quality of life. And also explain again, there are risks. So are these impairments that you are experiencing worth the risk of a surgical procedure? And this is the clue questions that can answer the question from indication.
Yeah, because if you can cope, we don't. I mean, like there is no indication. And again, it's always a mutual exchange between neurologist and patient. It's not the neurologist as the complete vision. The patient needs to be informed.
There is no magic formula that defines one patient and it says this patient is a candidate or not. It's always a question of shared decision making. So the patient must take the decision themselves, but to take the decision, they should have the right information. That's very important.
Yeah.
Another question, once you have a DBS, how often do you need to come to check up?
Again, it depends on the technique that you use in that center. It depends how successful it is. In the first year, there are many adjustments. We see the patient very often, even once a month. Our service is basically 24/7. So if there is an emergency, they call the nurse and then we shuttle the patient after a few days. But then when things are set and they're functioning, actually, I see the patient every 6 months, and I have patients that I haven't seen for 1 year. I'm in contact with them. We are in contact by video consultation, by email, but if they don't feel that they need to come, at least once a year, because we need to check the system when it's very successful. It happens. There are very successful stories that really the patient forget to come, but there are also not successful stories that, or there are in the middle stories that, they are happy, but obviously they're not treated fully, and maybe they need a little bit of botulinum toxin. So the DBS improve of 40%, 30%, and they treat the rest with botulinum toxin. So we forgot about that, but there are people that also still continue smaller dose of botulinum toxin.
Yes, and that's also our experience. And another question is, can you feel the leads and the device?
Actually, this is a question that you should ask another person with dystonia, and that's why I show you the blog of Lucy, my patient, because she has developed a blog really to share her experience of having or carrying the DBS device. She's very open. If you mail her, she will tell you, but you don't feel them, okay? You don't feel them into the brain, so you don't sense that in the brain. You don't feel the electrical current. If you feel it, it's because there are side effects. Some patients might complain after a few years about the wire that are pulling sometimes, especially with the old wires, because they, you know, they were rounded in circle. I don't see that much in dystonia. I see more in Parkinson DBS patient. But again, they sometimes can be, and there are also described sharing experience with colleagues or patients that, you know, they couldn't cope with the idea of having a device. So they couldn't live thinking. It's a very important really to talk about that before the surgery. Say, no, I cannot cope with the idea that I have something inside myself. I don't know, which is your experience, Fiorella?
Yes, so yes, I have to say, we also hear from patients that the leads in the head, you cannot feel them. You can feel some fettering of the wire here, and it's actually not the wire itself, it's some scar tissues that with the time goes around the wire. And I think the reason why patients with dystonia feel it less is that they move more, and that's a way to prevent that. What you can feel is the battery. The battery, we haven't shown you, there was one cartoon in your presentation, but it's more or less this big, and it goes on your chest. So especially in the first period, you do feel it. You feel that there is something under the skin. If you move your arm, you see that the muscle is going to move the battery. If you sleep on one side, you feel it. But then with the time, your body gets used to it. So you just forget that you have it.
And then it also depends, depending on your anatomy, how deep the surgeon positioned the battery. I had few patients, for example, with DBS, that they were bothered by the battery. I don't know, they had like some discomfort in the shoulder. I don't know why, but maybe it's the trajectory of the wire like caused that, or was like a compensation that they had, but it's very rare. They usually, at the beginning, that is another adjustment, no?
Yes.
That you need to be, you know, we need to take care of. But
maybe connected to that is also an aesthetical question, because I mean, young people, young women may ask that, what can you see from outside when you have this system? Yeah. So basically you have two scars in your head, and your hair will grow over it. That's not visible from outside. Everything is under the skin, so you can't see wires, you can't see anything particular. If you are particularly skinny, you do see the battery a little bit bulging here on your chest, or where the battery is placed. Sometimes it's placed also in the abdomen. And you do see one scar here where the battery is put. So if you are with a bikini, that could be visible, but it is not something that is really, really visible from outside.
It's you can cope with that. Yeah.
Yes. Our question is, do you need physiotherapy after DBS?
Great question. That is depend on your health system. If you know have a physiotherapy, I think that is crucial, because first of all, physiotherapy is very important for dystonia, but has not been structured yet fully. You know, starting now a few studies in the Netherlands. Marina Tyson has coordinated this study, very important. So we are understanding more, especially for people that we have operated with generalized dystonia. We have suggested even like more physiotherapy after, or like children that have a generalized dystonia, because some of them, they never acquired some motor skills, so they really need to learn. So it's crucial. There are few countries where, for example, Italy, there is a very good neurophysiotherapy network, I have to say, and it was easier to get access in the outpatient setting to neurophysiotherapy for dystonia patient. It varies among countries. I think it's one of those unmet need which Dystonia Europe, as patient advocacy group, should really advocate for the patient to get access to physiotherapy as a rare disorder, because it really I think that really can make a difference. Fiorella, you live in a place that, you know, is very developed for physiotherapy. What do you think?
Totally, yeah, indeed, what you say, in the Netherlands, the physiotherapy is very much developed for dystonia, and there are courses for people, physiotherapists who want to learn. I have to say, everything we are going to say is not evidence-based, but this is because there are not enough studies on physiotherapy. They have to come. But my personal feeling, my personal experience is that physiotherapy is very important after a DBS, especially in people who have generalized dystonia, but also in cervical dystonia, because you have to think your muscles have been in the wrong position for so long, and they maybe have developed some on one side more power than the other side, and then you do the DBS and suddenly your body has another posture. So the muscles have to learn to deal with the normal posture. So you have probably to train those muscles that you have not used for so long time, so much time. I think my feeling is that the physiotherapy is very important. Of course, which kind of physiotherapy should be used, that is unfortunately not completely investigated, but I think it's important to do physiotherapy and sport in general.
Yeah, I totally agree. But we will know more. I think that it is coming a lot to on that of the next.
Yes, it is. How often do you change the battery?
Okay, so how often you change the battery? In the past, before rechargeable batteries, very often, because we use non-rechargeable batteries, and that unfortunately some of the batteries also last for 2 years, especially in dystonia where we use very high intensity. Whereas now we have a new rechargeable battery that they promise that they should last 20 years. At least we have one set of battery that lasts for 10 years. The first set of rechargeable batteries that I've been using starting 10 years ago, they had last 10 years. So after 10 years, they started to lose charge. We will see with this new one that I'm just using rechargeable batteries in dystonia, except a few patients that cannot cope with charging, or we were not sure that they could cope with charging, but we have been using rechargeable batteries so far, so they are expected to last a lot, so 20 years, 25. I don't know, do you use rechargeable batteries in dystonia?
No, actually, I have to say we do at the first time always a non-rechargeable battery. And because we have a lot of patients also with dystonia where we don't need to use a lot of energy, and then the battery can last even 4 to 5 years. And changing the battery is as well a small procedure we do under local anesthesia. It's half hour. They just open the scar, change the battery and close again. And then you don't need to recharge. If it appears that the patient really needs a lot of energy and the battery lasts only 2 years or 2.5 years, then when we replace, we put a rechargeable battery. It is important to mention how does this work. It's true the rechargeable battery can go on for 15 years, but you have to recharge it. And if you use a lot of energy, you might have to recharge it every day. And this implies that you have to sit and put a belt on your body and stay still for half hour every day. If you forget once, it doesn't matter. If you forget twice, it could be that the battery goes off and then it will come back. So you have to go to the center to switch it on again. So it is not nothing. It is something you have to take care about. That's why we don't do it in every patient in the first place. There is another question, if you always do DBS procedure under general anesthesia, so asleep.
Yeah, in London, in our center, we do always under general anesthesia because it's our technique to use general anesthesia, also in Parkinson. But in dystonia, we would have done that because also to avoid the discomfort. So we have operated without general anesthesia in Parkinson until 2 years ago. But then we transitioned to general anesthesia for all our DBS patients except for tremor, and patient actually the outcome is the same, is even better because the procedure is shorter and the patient likes very much. But there is a lot of difference between the centers. I bet that Fiorella does differently.
Well, now we can offer the procedure on anesthesia. It all depends on the symptoms of the patient. There are some patients who cannot afford staying in the operating room awake because of their symptoms, and then we just do it on the general anesthesia. If the symptoms are milder or they can allow to stay, we offer also to do it awake, and then this offers an extra chance to check for the possible side effects during surgery. So I think we have to close. The very quick question, the last question was, does insurance cover the cost of DBS? Well, that very much depends on which country you live and which insurance you have. So we cannot answer this question in general. So I think we have to conclude, Francesca.
Yes, I can see Monica there and Adam. Yeah.
Yes, Monica and Adam, I think we can conclude. In my view, it was very informative webinar. I know that there are thousands of questions that the patient with dystonia may have. My advice is don't hesitate to ask your neurologist. And if you feel that your neurologist doesn't know enough, then ask to be referred to another neurologist, because nowadays it is your right to have all the correct information about all the available treatments. Worst that can happen is that they screen you and they say, okay, this is not an option for you at this moment, but at least you know that. So never hesitate. If you doubt, just ask the question and seek information.
I totally agree with you. That is a really very important message. And thanks a lot, Monica and Adam and Dystonia Europe, for giving us the possibility to do that together. Actually, I enjoyed very much.
Thank you very much, both Francesca and Fiorella. This was very, very informative and very interesting. And I think we got lots of answers to many, many great questions that we got. And this presentation, this is recorded, and we will have it on our YouTube channel afterwards. So people can always go back and look at it. And I really like all the things that you brought up and how important it is to talk to your neurologist and to have this to think about your quality of life. If the treatment is not working, you have to talk to your neurologist. You have to discuss what are your options, what can you do, and then decide how to move forward and what you can do.
Exactly.
Yeah. So Adam, do you want to say something?
Yeah, I think also that was very informative webinar, and it will be good to have it on our YouTube channel and Facebook for people to recall that and watch it if somebody couldn't attend the meeting. And yeah, so thank you for joining us. I really appreciate that your time, and thank you to attend this also for the questions and for joining here and on the Facebook. And I also want to let you know that our next webinar on different topics we will host on the half of October. So thank you very much all. Have a nice evening.
Bye-bye.
Thank you, everybody.
Bye.
Bye. Thank you.